Hi, everyone, and welcome back. Thanks for joining us for video number 2. Let's briefly recap what we discussed in the first video. Initially, we started by identifying the criteria used to diagnose ARDS, the Berlin criteria, and then we discussed 4 key components of ARDS care. Low tidal volume ventilation, which should be set according to the patient's ideal body weight, PEEP titration to keep alveoli recruited, deliberate fluid management to combat the accumulation of non-cardiogenic pulmonary edema, and prone positioning for refractory hypoxemia. There are other therapies that you may have heard of for ARDS, and these include paralysis, pulmonary vasodilators, and extracorporeal membrane oxygenation. The evidence behind these therapies is not as solid as the therapies we previously discussed, and there's no indication at this point that these interventions are more or less effective for COVID-19 ARDS than for other causes of ARDS. And in general, these strategies are reserved for the most severe cases of ARDS. If considering using these strategies, I strongly recommend consulting with an available critical care specialist, as there's much nuance in decision making. But let's talk about these 3 different advanced therapies now. So for paralysis, the use of paralysis via neuromuscular blockade in the management of ARDS has been evolving substantially over the past decade. The primary utility of this is to combat ventilator dyssynchrony, which can lead to compounded lung injury. In general, this therapy should not be broadly applied to all comers with moderate to severe ARDS, but rather should only be employed on a case-by-case basis. Pulmonary vasodilators. Inhaled nitric oxide or epoprostenol may be used to improve VQ matching in patients with ARDS. Trials are ongoing actually to see if there's an antiviral effect of nitric oxide on SARS-CoV-2. Providing epoprostenol generally requires a clinician to interrupt the ventilator circuit to add in the nebulized epoprostenol, and that might risk aerosolization. So for this reason, some institutions have preferred nitric oxide. Importantly, though, neither agent has been shown to improve mortality in ARDS. And finally, ECMO. This is a resource-intensive therapy that may be available at some highly specialized centers. When considering this option, clinicians should consult with ECMO experts to discuss institution-specific criteria for the initiation of ECMO support. So now that we've covered the major therapies for ARDS care, let's return to our patient and see how her case progressed. So after intubation, she received low tidal volume ventilation with tidal volumes equaling 6 cc's per kilogram of her ideal body weight. And you can see that on this screenshot from her medical record, her tidal volume was 420 cc's. When assessed via the ventilator, the compliance of her respiratory system, which indicates how stiff her lung and chest wall are, was very low. Her PEEP was initially increased according to the ARDS-NET low PEEP table, but her hypoxemia did not improve substantially. The team then decided to place her into the prone position. The arrow indicates when this happened. You can see here the changes in her FiO2 and her PaO2 with this maneuver. So without changing her FiO2, her PaO2 increased from 127 up to 216, and her pulmonary compliance also improved. And as a result, later on, her FiO2 could be lowered. So once she was in the prone position, her P to F improved, her FiO2 was lowered, and her compliance improved to 30 cc's per centimeters of water. The team made sure she was maintaining a net even or net negative fluid balance, including using renal replacement therapy and concentrating the infusions of her medications. Eventually, her hypoxemia improved, and she was able to tolerate being in the supine position. And PEEP and FiO2 are further decreased, and she is actually eventually extubated after 16 days of invasive mechanical ventilation. So our ARDS story ends here, but there's a lot more to ICU care than just management of hypoxemia. For that reason, I'm going to transition and focus on what ICU providers can do to ensure that they're providing high quality ICU care to all of their patients. These strategies should be used in addition to routine quality standards such as removing Foley catheters and appropriate DVT prophylaxis. So I want to introduce you to the ABCDEF Bundle, also called the A2F Bundle. Despite competing evidence about some elements of ICU care of the critically ill patient with the COVID-19, there is no question that high quality ICU care should include elements of the ABCDEF Bundle. These interventions have not only a strong evidence base for improving patient outcomes, but also can be employed easily by healthcare providers in a variety of settings. So let's go through them one by one. A stands for assessing, preventing, and managing pain. This should be performed routinely. Multiple standardized tools exist, but the key points include using complementary pharmacologic agents such as opioid and non-opioid analgesics, pre-medicating patients before painful procedures, and awareness of altered pharmacokinetics during critical illness. Treating pain is essential given the strong relationship between poor pain control and delirium. B stands for both spontaneous awakening and breathing trials. A spontaneous awakening trial is a period of time when narcotics and sedatives are stopped to assess the patient's underlying mental status and to provide some respite from the deep sedation often required for patients with ARDS. This is also referred to as daily interruption of sedation. A spontaneous breathing trial is a brief cessation of mechanical ventilation support used to assess a patient's readiness for extubation. This should be performed when the patient has been switched to a spontaneous mode of mechanical ventilation and has a steady trajectory towards improvement. This should not be done during the initial stages of ARDS, as lung protective ventilation is paramount during this time. The combination of a daily SAT and SBT has demonstrated improved patient outcomes, including reduced ICU length of stay and ventilator days in ARDS patients. C stands for choice of analgesia and sedation. Sedation should be monitored using a standardized scale, such as commonly used as the Richmond Agitation Sedation Score. And clinicians should use the lightest sedation possible, which achieves the appropriate ventilator synchrony and analgesia. Though medication shortages may limit your choices, benzodiazepines should be avoided as much as possible, given high rates of delirium, of withdrawal syndrome, and worsened patient outcomes with this class of medication. D stands for delirium, assessing, preventing, and managing. Delirium is extremely common in critically ill patients and especially in those with ARDS. You should assess for delirium regularly, also using standardized tools such as the CAM ICU. If identified, delirium should be treated, preferentially with non-pharmacologic methods, in order to avoid polypharmacy and medication interactions. In particular, antipsychotics should be avoided given the lack of evidence supporting their efficacy, but if needed, short courses and small doses may be acceptable. E stands for early mobility and exercise. Within the limits of resource availability and infection control, early mobilization with physical and occupational therapy remains one of the best established treatments to improve outcomes among survivors of mechanical ventilation. Given the constraints of staffing during surge periods with the pandemic, there are some nursing-driven protocols available. And then finally, F stands for family engagement and empowerment. Involvement of patients' families and loved ones is essential. COVID-19 infection control measures have prevented our usual family communication patterns, and so providers should employ some creative strategies, which we'll talk a little bit more about in a minute. But in general, for the HF bundle, using this on a daily basis for eligible patients, this is associated with a lower likelihood of numerous outcomes, including death, continued mechanical ventilation, coma, delirium, use of physical restraints, ICU readmission, and discharge to a facility other than home. So this is key for you to use in your intensive care unit. There are some important ways in which we can adapt our ICU care practices for patients with COVID-19. This is especially important as we think about how to provide outstanding care, but also how to protect ourselves and our colleagues. Firstly, capitalize on the time spent in patient rooms. This means trying to find ways to concentrate your care and do as much as possible at once so that you can provide efficient care while saving personal protective equipment. Consider bundling lab tests, assessments, procedures, and medications together. Critically ill patients often need procedures done, and you should think carefully about whether or not you anticipate they might need a central line as well as an arterial line, for example, and perform them together. In some cases, you can use medications that are dosed less frequently to reduce the number of times that you need to enter the room. Secondly, try to find ways to minimize both patient and provider exposure. If working in a team of clinicians, designate select providers to examine the patient. It need not be everyone. Consider keeping IV pumps and other machines outside of the patient room to allow for easy and frequent adjustments if needed. And then finally, consider using cell phones or notes to communicate with the providers who are in the room rather than having to enter yourself if not necessary. Finally, clear and timely communication is more important than ever as both patients and families experience increased anxiety, stress, and isolation due to the pandemic. Visitor restrictions during the pandemic have also created an opportunity for us to be creative about how we involve families and loved ones. ICU teams can schedule phone calls to provide updates throughout the day or allow the family to listen in on rounds via speakerphone. And if available, you should utilize video-capable interfaces so that families can see what's going on. So here are the take-home points for our video. Thank you for joining me, firstly. So ARDS, a morbid complication of severe COVID-19, is diagnosed using the Berlin criteria. Once it's been diagnosed, you should employ core components of ARDS management. And this includes low tidal volume ventilation, PEEP titration, deliberate fluid management, and prone positioning. Other advanced strategies can be considered on a case-by-case basis. Regardless of severity of ARDS, all COVID-19 patients in the ICU should be assessed with the A2F bundle on a daily basis. These measures are key to the provision of outstanding ICU care, which impacts patient lives and long-term outcomes. Finally, there are some important modifications to make to typical ICU care in order to protect you and the rest of your team. Good luck, and thank you for joining me.